Hi, this is Jeff Myers, and we're going to talk in this brief presentation about aspirin administration as well as assisting a patient with their own nitroglycerin for EMTs. I am the Regional EMS Medical Director for the LTS region. So let's get into BLS aspirin and nitroglycerin in the 2021 Pennsylvania BLS protocols. They do allow administration of aspirin by EMTs, as well as assisting the patient with their own nitroglycerin in cases of suspected chest pain, cardiac related chest pain. In looking at the criteria for this protocol, we're identifying patients with chest pain that is likely cardiac in origin. Some of the features that suggest that the patient's chest pain is cardiac in origin includes the pain is located behind the sternum or retrosternal. Patients often describe this pain as a pressure quality or a heaviness, a squeezing sensation. Some patients will describe it as the classic an elephant sitting on my chest or a heavy weight sitting on my chest to note that pressure. This pain oftentimes will radiate to either arm, either shoulder, to the neck, or to the jaw. But in some cases, the pain doesn't radiate at all. It stays in the middle of the chest. A lot of patients do have some associated shortness of breath, which may be worse with exertion. Some patients will have nausea, vomiting, diaphoresis, or lightheadedness, depending on their vital signs and the portion of the heart that's affected by the pain. Many patients report that their pain is worse with exertion, which makes sense because the heart is having trouble getting oxygen, and the more we exert, the more the heart needs oxygen, the more the heart uses oxygen, and if it can't get it, it's going to cause more pain. Some people will report a recent history of developing some chest discomfort that may be minor in their view, but developing chest discomfort periodically with exertion that goes away with rest. That becomes more and more frequent until this episode that began causing them to call 911. Most patients who have cardiac-related chest pain are over 30, or some patients who are under 30 have known cardiac disease. However, this can also occur in a small group of younger patients. Patients who have a history of recent cocaine use within the few days prior to the onset of their chest pain are also at risk for ischemic cardiac-related chest pain. Cocaine is a drug that causes the coronary arteries to spasm and can cause them to spasm to the point where it decreases the blood flow to the heart, causing pain. But cocaine also will accelerate the plaque buildup in those arteries. So if you can imagine, if it accelerates the plaque buildup and then you continue to take cocaine, you may actually develop a clot in those arteries at a younger age. Exclusion criteria, mainly this protocol isn't used for patients who have chest pain where it's believed to not be cardiac. Now, some of the features that suggest that this is not cardiac chest pain includes pain that is pleuritic in nature or gets worse with deep breathing, pain that's positional or worse with movement of the arms, twisting, bending. Some of those features tend to have another cause of chest pain, along with patients who are under 30 typically have not developed, unless they have other medical issues, for example, diabetes, renal conditions, or high blood pressure, tend to not have other medical conditions that cause the development of plaque in the coronary arteries. Now, I do have to caution you that if you are unsure whether the pain is cardiac in nature versus not cardiac in nature, then it's best to err on the side that it is cardiac and think about administering aspirin. because sometimes patients will have pain that does not fit into the typical symptoms or descriptions of cardiac-related chest pain. In terms of treatment, initial patient contact, we're focusing on the ABCs. If the patient is also having difficulty breathing or there is signs of poor perfusion, for example, they're pale, diaphoretic, they look like crap, essentially. They have a delayed capillary refill. Their oxygen saturation is below 94%. They're looking like they're having a tough time breathing. Then go ahead and administer a supplemental oxygen. Go ahead and check to see if the patient is allergic to aspirin. As long as they're not allergic to aspirin, you can go ahead and administer 4 81 milligram aspirin tablets. These are meant to be chewed because chewing those aspirin tablets will rapidly cause the onset of action for that aspirin. Aspirin is designed, what it does is it makes the platelets less sticky. So if you can imagine that you've got plaque buildup in the arteries, a clot forms in the artery, and we give that patient aspirin, it's going to prevent further clot from forming on that area that's already irritated and forming clot. As I said, chewing the aspirin will make it come on very, very quickly within minutes to start to have an effect to help that patient. And certainly there are a good percentage of patients that have a decrease in their pain just from getting aspirin. It works that quickly. If the patient does express that they have an allergy to aspirin, it's important to ask them what their reaction is. Some patients are truly allergic to aspirin where they develop hives or they develop trouble breathing, or they have a medical condition where they've been told not to take aspirin because it affects their blood and can cause severe anemia. Some patients, however, have been told not to take aspirin because they've had bleeding in their stomach in the past, or perhaps they're already on another anticoagulant, for example, warfarin or Eliquis or Xarelto. In those patients who are on another anticoagulant medication or who've had GI bleeding in the past, and that's their only contraindication to aspirin, one dose tends to be safe for them to take, and I will usually explain to patients why we're giving the aspirin and why it's important to take the aspirin in this instance as a one-time thing. Usually they're warned not to take aspirin or non-steroidal anti-inflammatory medications on a regular basis because it can cause additional bleeding. However, if the patient adamantly declines aspirin, that's okay. We can defer that discussion to the emergency department. Now, if the patient already has prescribed nitroglycerin, for example, it's a patient who has known coronary artery disease, they've had an MI in the past, they have a history of heart failure, or they have angina, a lot of patients in those situations are prescribed nitroglycerin. You're allowed to help the patient take one of their sublingual nitroglycerin tablets if they're not able to take it themselves, or you can suggest that they take nitroglycerin as they've been prescribed. Now, if the patient has taken any medications to treat erectile dysfunction in the last 48 hours, for example, Viagra or Cialis, Revatio, or Levitra, then do not let them take their nitroglycerin. It can cause severe, severe hypotension that is very difficult to reverse. So as long as the patient's blood pressure is above 100 systolic, they're able to take their nitroglycerin. If you do have to assist the patient, then it's one tablet that's dissolved under the tongue. Now, if they have continued chest pain and they need additional assistance in terms of taking additional nitroglycerin, then the protocol asks you to contact Med Command to discuss that and make sure that it's safe to do that. Now, if you have ALS en route and will be there shortly, then you may defer that to the paramedic. If there's any question on the appropriateness of administering aspirin or assisting with nitroglycerin, please feel free to contact Med Command or wait for the ALS provider to arrive to confer with them. There are some notes in the protocols. Please review those notes and make sure that you're familiar with those notes. As we've talked about, this is a fairly straightforward way to assist your patient who is complaining of chest pain that may be cardiac in nature. As I mentioned before, and I can't reinforce this enough, that it's better to err on the side of caution. If there's any question whether the patient's chest pain is cardiac in nature versus non-cardiac, to treat it as if it's cardiac. This is especially if there has been no trauma to that patient or mechanism that suggests that there may be an injury to that patient, and especially if they have a past history of cardiac disease, coronary artery disease, or if they have some of the medical conditions that can cause coronary artery disease, for example, diabetes, kidney disease and dialysis, high blood pressure, and hypercholesterolemia. That's all I have for this presentation. If there are any questions, please feel free to reach out to me. Otherwise, have a great day and be safe out there.